Hello, my name is Dr. Praveen Bitoy from the Department of Anesthesia and Perioperative Medicine in London, Ontario. This video has been created purely for the use of third-year medical students who are having a lecture from me. The topic of the lecture is acute pain management and multimodal analgesia. The objectives of this talk are as listed. Number 1, we will define pain as well as comment briefly on its public health importance. Number 2, we will go over the very basic neurochemistry of pain and transmission. Number 3, we will talk about the concept of multireceptor, or otherwise known as multimodal analgesia. Fourthly, we will go over the different modalities of acute pain management. And fifthly, the most important perhaps, is all of you will be able to write adequate analgesia orders. So let's talk about the first objective. What is pain? How would you define pain? I'm sure all of you have experienced pain or have seen people in pain, but how would you define it? A generally accepted definition from pain societies across the world would define pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Note that there could be no actual tissue damage, but this would still be defined as pain. A second definition is given briefly below, which is pain is a physiological consequence of impending or actual tissue injury. It is very protective. Now that we have a definition of pain behind us, how might we classify this pain? There's multiple different ways of classifying pain. None use more than the other. So the 4 different ways that I'm going to talk about classifying pain are as listed. We can either classify it by intensity, or by duration, or by mechanism, or in fact the cause of the pain, or perhaps in the clinical context in which the pain is experienced. If we think about intensity, we could easily classify pain as mild, moderate, or severe. If we classify pain by duration, we can classify it as either acute, chronic, or an in-between convalescent pain. Acute pain lasts up to 2 weeks. Convalescent pain lasts between 2 weeks and 3 months. And if pain persists beyond 3 months, we would call it chronic pain. The third way we might classify pain is by mechanism. In the mechanisms, the first type we will look at is physiologic. Physiological pain is defined as a brief, rapidly perceived, non-traumatic discomfort that identifies a potentially dangerous stimulus. Note that in this case there does not have to be any actual tissue damage. Physiological pain is also associated with learned avoidance and adaptation that can modify future behavior, i.e., we don't have to sit on that sharp pin again or put our finger in the hot flame. With nociceptive pain, there is actual tissue damage. This tissue damage is followed by a humoral response as well as a local inflammatory reaction. Nociceptive pain can be divided into somatic pain or visceral pain. Somatic pain is very well localized pain. Visceral pain is poorly localized. Referred pain is a special type of visceral pain that occupies the same dermatomal distributions as the site where pain is actually felt. The third type of mechanistic pain would be neuropathic. In neuropathic pain, there is actual damage to nervous tissue. With other types of pain, we assume the nervous tissue is actually normal. Here the pain is felt as a non-specific burning, electrical, or shooting type pain. This usually results in chronic pain. There are 2 major types of chronic pain, CRPS1 and CRPS2. What we see with neuropathic pain is completely abnormal responses to usual stimuli. For example, a touch might be felt as pain. The fourth grouping in this classification would be mixed pain. In mixed pain, we have a combination of neuropathic pain and physiologic pain. A good example of this is back pain, where you initially have damage to tissues, but this subsequently results in damage to the nerves. The fourth way that we might classify pain is by the clinical context as listed in the slide. In this case, we're looking at the clinical situation. For example, either post-surgical pain, pain related to malignancy, pain related to degenerations such as arthritis, or neuropathic pain. The scope of chronic pain is quite beyond the scope of this talk. So how does pain get from the actual site where it is felt to the brain, which is where it's appreciated? Well, there's 4 steps in this process. The first is transduction. This simply means that there is a stimulus, whether it's a physical stimulus or a chemical stimulus, which has to be then converted to an electrical stimulus, because this is the only type of signal that can be transmitted by nerves. This stimulus is then transmitted along to the brain. However, before it reaches the brain, there is some modulation of this stimulus, and it is important to note that it is modulated even before the final pathway, which is perception. This is when we actually feel the painful stimulus. This slide is a diagrammatic representation of the previous slide. Note that there is a stimulus which is then transmitted to the spinal cord. Notice the descending inhibitory fibers which react after the pain has reached the thalamus, and once this signal has been modified is when we become aware of it. This is a fairly long list of neurotransmitters involved both in the excitatory and the inhibitory pathways of pain. There is no need to learn any of these. These will come up at later dates. Of note is that substance P is actually found in both the excitatory and the inhibitory pathway. This slide shows you a sensory motor nerve end plate. The main purpose of this slide is to show you how complex the interactions are when there is a stimulus. Notice that multiple neurotransmitters are involved both in the inhibition and the excitatory portions of pain transmission and transduction. While the main focus of this talk is the management of perioperative pain, before we head there, we should delve into the ill effects of untreated or undertreated pain. We know that pain has an important purpose. In fact, it is important for the survival of young healthy individuals following life-threatening injuries. However, these same responses may significantly increase post-surgical morbidity, certainly in high-risk patients. In post-surgical patients, we know that pain stimulates the neuroendocrine stress response. This has effects on all systems in the body. With regards to the CNS, we know that poorly controlled pain can either initiate or exacerbate emotional distress. Patient anxiety is increased, and it's possible that this could lead to persistent pain states with the formation of chronic pain. We know that patients who experience significant pain do have effects on their sleep pattern. Looking at the pulmonary system, we see that poor pain control leads to atelectasis secondary to hypoventilation or pulmonary edema resulting from stress-induced hypervolemia. The magnitude of the symptoms is directly proportional to the amount of pain felt. Tidal volume is diminished and respiratory rate is increased. This effect is most pronounced with upper abdominal surgery or thoracic surgery. With regards to the cardiovascular system, we see hypertension and tachycardia. This is because of the high circulating level of catecholamines. We also see stress-induced increases in plasma viscosity and platelet-induced thrombosis. There is also coronary vasospasm secondary to platelet aggregation and release of serotonin. All these mean the heart works harder, which contributes to the increased chance of myocardial ischemia. Blood is diverted away from the operative site, thus reducing healing. With regards to the endocrine system, we've already spoken about the increase in the level of catecholamines. There's also an increase in the level of catabolic hormones and a decrease in the level of anabolic hormones. This results in negative nitrogen balance and increased blood sugar. All these contribute to diminished wound healing. There's also an increase in arginine vasopressin, which causes fluid retention. With inadequate pain control, we also see decreased immunity. We notice that there is a stress-induced lymphopenia, granulocytosis, and decreased natural killer and T-cell activity. There's also diminished release of immunoglobulins. With regards to coagulation, we're already aware that surgery induces a hypercoagulable state. This is further compounded by inadequately treated pain. With regards to the gastrointestinal system, we know that blood will be diverted away from it. This will result in decreased digestion. This also results in decreased gut motility with perhaps an increase in nausea. pain can directly cause nausea. It is quite common to have oliguria post-surgery. This effect is compounded again by undertreated pain. This should leave you in no doubt that undertreated pain has multiple physiological effects. These effects are generally undesirable. If an adverse event is regarded as a negative or bad result stemming from a diagnostic test, medical treatment, or surgical intervention, could we perhaps say that pain is an adverse event? If we do call it an adverse event, would we pay more attention to it? These are questions for you to answer. So why aren't we doing a better job with pain management? Well, there appear to be multiple barriers to this. This slide highlights some of them. Of importance is that there's often a lack of accountability for pain management. Everyone leaves it for somebody else. There's often a tendency to underestimate the amount of pain a patient will feel. We also do not recognize variability within a patient as well as amongst patients. And we certainly need to educate both care providers as well as the patient. An important fact not recognized by many physicians is that untreated pain can often lead to chronic pain. This is a lot more common than most people would ever expect it to be. Thus, this further highlights the need to treat pain when it is painful and to treat it effectively and quickly. There are multiple modalities with multiple routes of managing pain. As doctors, we will use many of these modalities or routes, but remember, pain control is not only in the realm of doctors. There are certainly lots of other people out there who can be helpful in the management of pain. You should have a sense of how complex the pain pathways are, with multiple connections at multiple sites. Thus, each of these sites is a site of action that we can apply some kind of therapy in order to manage pain. Thus, we've developed the concept of multimodal or multi-receptor analgesia. This is an effort to try and tackle the pain at multiple different sites along its pathway. Patient-controlled analgesia was developed to overcome many of the barriers mentioned in the previous slide. However, it has not proved to be the catch-all and be-all of all pain management. Patients are often unhappy when they're on PCA. There are multiple reasons for this. The advantage of PCA was thought to be that the patient would now have drugs available to them all the time at all times. However, the disadvantage is that you have to be awake in order to actually use your PCA. You also have to be educated adequately so that you don't feel that you will become addicted to the drug. This slide shows a variety of PCA regimens in use. Note that in London we mainly use the hydromorphone and the morphine ones. The occasional time we will use fentanyl if a patient has sensitivities or allergies to morphine and hydromorphone. I am sure that all of you are aware of the opioid receptors as listed on the left-hand side column. A new naming system will be used in the future. Of note is that the sigma receptor is thought not to be a true opioid receptor, hence there isn't an equivalent name for the sigma receptor. With continuous use of opioids, the first thing one might note is tolerance. Tolerance is defined as requiring increasing doses of opioids to maintain the same level of analgesia. This could proceed on to physical dependence. Physical dependence is defined by when a patient experiences some unpleasant symptoms such as sweating, shaking, cramping, and diarrhea with discontinuation of the opioid. The next step from this is psychological dependence, in which we see drug-seeking behavior and often drug administration for purposes other than pain control. The next step from this is addiction. Addiction is an extreme form of psychological dependence, where patients demonstrate impaired control, craving, compulsive use, and continued use despite harm. Opioid addiction is driven primarily by psychological maladaptations. Unlike physical dependence, opioid addiction is rarely observed in patients suffering moderate to severe acute pain, and when opioids are used in this circumstance. Opioid hyperalgesia is a separate entity where patients actually complain of increasing or new pain syndromes when they are on opioids. This is most commonly seen with short-acting potent opioids such as remifentanil. Morphine is still the opiate that everything else is compared to. Morphine was originally derived from opium. It is now obtained from synthetic sources. We know that morphine provides good analgesia and has multiple side effects such as mood alteration, respiratory depression, cough suppression, nausea and vomiting, constipation, increased biliary tract tone, histamine release, and itching if given neuraxially. Morphine can be given by multiple routes, and the route used should always be the least invasive route. Codeine is a weak opiate and exerts its action because of conversion to two active compounds, i.e. morphine and codeine 6-glucuronide. It certainly has good antitussive properties and can be used for mild to moderate pain. The two other commonly used opiates are hydromorphone and fentanyl. Remember, hydromorphone is about 5 to 7 times more potent than morphine, and the side effect profile is thought to be slightly better. Fentanyl is commonly used in the operating room. It is a short-acting narcotic, hence its use is mainly confined to the operating room and not the post-operative period. The non-steroidal anti-inflammatory drugs are the commonest class of analgesics used the world over. The prototypical one has been aspirin, and we know that aspirin has central and peripheral effects. We know the importance of prostaglandin, leukotrienes, and other agents which are involved in nerve transmission and modulation. They are not important by themselves, but sensitizing the peripheral nerve endings to other mediators is why they're important. Hence, the non-steroidal agents block this effect. We know that there are two types of receptors, the COX-1 and the COX-2 receptors. Most NSAIDs affects both COX-1 and COX-2 receptors. We do have some newer COX-2 drugs which do, however, have a small amount of COX-1 effect. This slide shows the pathway to formation of tissue-specific prostaglandins. Important in this slide is to notice where COX works. Hence, the COX inhibitors would be working at these points in the pathway. The most commonly known and widely used NMDA blocker is ketamine. Ketamine was initially developed as an anesthetic induction agent. We know that the NMDA receptor is important in nerve transmission, hence blocking this receptor can modulate nerve transmission. Ketamine in small doses is very effective at blocking the NMDA receptor. The alpha-2 ligands were initially developed as anticonvulsive agents. The first drug in this group was gabapentin. We now have a new drug in this group called pregabalin. These drugs are most commonly used for neuropathic or chronic pain. However, there is increasing usage in the perioperative period for the management of acute pain. Clonidine and dexmedetomidine are both alpha-2 agonists. This means they stimulate the alpha-2 receptor, which is involved in the modulation of pain. Clonazepam is a benzodiazepine. We are aware that it is important to use anxiolytics in someone who has long-standing pain. Even in acute pain circumstances, benzodiazepines might be useful. Peripheral nerves are mixed nerves, and they contain both myelinated and unmyelinated efferents and afferents. Myelination is a better insulator, and this causes faster nerve conduction. We know that the interior of the nerve is actually negative compared to the outside. The negative value is somewhere between -60 and -70 millivolts. We know that depolarizing the nerve takes us above zero. Local anesthetics work because they block sodium channels, and this prevents the depolarization of nerves. There are two broad groups of local anesthetic agents. The first is the ester group, and the examples are listed below. The second is the amide group. Drugs in the amide group are much more commonly used than drugs in the ester group. However, if you do have somebody who is allergic to one class of local anesthetics, the other class can certainly be tried. We know that only a small percentage of the local anesthetic actually enters the interneuronal site. There are certain additives to local anesthetics which usually help either prolong the duration or speed on the onset of action. Infusion of local anesthetics, most commonly lidocaine, has shown to be very beneficial in terms of systemic analgesia. This is not something we usually think of, but there certainly are studies out there that show the efficacy of an infusion of lidocaine. This concludes this brief presentation. I hope it has been somewhat useful to you. This is the first time I've done something like this, and I would appreciate any comments or suggestions for improvement.